Hi, my name's Dr. Bertie Vidgen. I'm a research fellow in online harms at the Alan Turing Institute, where I work on our public policy program on online hate speech, misinformation, and extremism. And today I'm here to talk about understanding and countering vulnerability to health-related misinformation during COVID-19. So before I get going, I'd really like to just thank everyone who's been involved in this research. There's many other people who aren't just named here, but there's myself, there's Becky Inkster, who's based at Cambridge and the Turing Institute, Mirto Pantazi, who's a postdoc at Oxford, Zoe Anastasiou, who's one of our research assistants at the Turing, Helen Margetts, professor at the University of Oxford and director of the public policy program, and then Harry Taylor, who's a PhD in Manchester and also a research assistant at the Turing. So huge thank you to everyone involved, and of course everyone else at the Turing and beyond who has helped to make this possible. I should also add that we are funded by the Health Foundation, who very generously gave us a grant at the start of the pandemic, and also the Turing Institute, which gave some funding to support our involvement. So I just want to launch straight into this and talk about the problem of false information during COVID. I think what's really important to recognize here from the very outset is that misinformation is always contested. What's misinformation to me might just be the truth to someone else. And often we're not just talking about things which are blatantly false, or I can point to a dictionary and say, look, this is clearly wrong. Look, here's my evidence. You're defining this in the wrong way, or you've made a very straightforward empirical claim, and I can say, look, that's incorrect. Often that's not what we're dealing with when it comes to misinformation. We're dealing with speculation and conflation of facts with opinion. We're dealing with people making assertions and extrapolating too far. It's a very, very complicated and complex landscape. So that's misinformation in general. I would, however, like to make the argument that that's perhaps not the case here. And when we're in the context of health-related misinformation, which leads to very tangible health outcomes and health impacts during a global health crisis, actually we can start to say that some things have better evidence and some things don't. And if we're not willing to make those sorts of claims and to recognize things which are incredibly pernicious and can really lead to tangibly bad outcomes for people, then we're in quite a problematic space. So I think that's very important to recognize from the start, is that we are talking about forms of content which lead to real harm in a very immediate and direct way. And of course, we're dealing in a landscape where things are changing fast. Public attitudes towards expertise and scientific knowledge has changed hugely during COVID. The science itself has changed. The things that we're suddenly talking about have changed. No one was talking about R numbers back in January unless you were a health expert, and now you can see that in any newspaper. So to give some tangible examples, and these are all taken from Ofcom. So drinking more water can flush out the infection. COVID can be treated by gargling with salt water. COVID can be treated by avoiding cold food and drink. And Ofcom has done a lot of survey work, which is really helpful. And they've shown that these things are being seen by quite a lot of people online. But I think that the challenge here, of course, is sure, a lot of people are seeing them, but how many people are believing them? How many people are looking at that and are saying, oh, that's really helpful. Great. I'm just going to go drink a whole load of water. I don't need to take myself down to the hospital. We don't know, is the truth. It's very, very hard to understand that. It's a very different question to how many people are exposed to false information. And there's a real methodological challenge here that, sure, some cases I can say, yeah, look, that was false information, and I recognized it and I wasn't fooled by it, and yeah, I've seen that and I knew it was false. There's going to be a whole load of other false information which I was exposed to and I just didn't realize it was false. And so there's a real challenge here in trying to make estimations of how much false information there is. So we find out that half of UK adults have been exposed to false claims. That's probably a minimum. That is going to be the minimum value, because by definition there are people who have been exposed to it and don't realize. And I should add that we are, one of our concerns here is, if we don't understand the problem well enough, if we don't understand who's truly vulnerable and why they're vulnerable to this information, how can we start to develop appropriate interventions? And that's very important to consider. But it's worth recognizing that the government has released some guidelines. The Centre for Countering Digital Hate has released some guidelines. There are bits of information out there to encourage people to scrutinise and reflect on content more critically. And whilst I personally don't think that we have the evidence base to say definitively that that's the best way of solving this problem, it certainly can't make the problem any worse. And there's also some new resources coming out which are helping us to understand the prevalence of misinformation, such as NewsGuard and other organisations who have done these live trackers. And they give you some sense of where the content is and how harmful it is and how many times it's been engaged with or seen. But this is the problem, that so much of the work has been on the supply side, has been trying to understand who's pushing it out and how much they're pushing out. What we don't understand in the same way is who's actually on the demand side, who's engaging with it, who's believing it, who's susceptible and therefore the most at risk. This is always worth saying, we aren't the first people to look at this. You never are. There's been some great research, especially in social psychology. If you're interested in this subject, and I'm reporting here on some preliminary, well, not even preliminary, I'm reporting on what we're doing because we're still in the process of getting the pilot and the full study confirmed. Go and have a look at some of this research. It really is very, very informative. So what we're trying to do, we have two research questions. First of all, what factors are associated with people who are more likely to believe health-related misinformation? And here we're looking at individuals. So we want to understand what traits, outlooks, features of individuals lead them to believe health-related misinformation. The second question is saying what features are associated with false health-related content that people erroneously believe is true. And that's a fairly wordy way of saying, look, even if we're all really good at not being duped by health-related misinformation, say, or we're really robust and we scrutinize, we work it out, nonetheless, some content will probably fool us in some cases. And why is that? Why is it that, most of the time, say, I'm completely good at detecting what's false and what's true, but there's some bits of content that I really struggle with, perhaps. And this is what we're trying to get at with the second question. So the first question is more of a between subjects design, and the second question is a within subjects design. And we're putting this on the Open Science Framework, so we have full transparency and everyone can see what it is that we're doing with our hypotheses. And so what are we doing? So we have developed a set of surveys and experiments which we're implementing through Qualtrics, and we're asking people a battery of questions to understand these features that we want to look into, and I'll be going into the hypotheses next. And then in the experiments, we're showing them different vignettes. So these are artificial social media-esque entries and posts, which we've generated, which let us understand people's susceptibility, because they then assess them. So then give them a rating of 1 to 7, and they say, look, I think this is very accurate, I believe in this. And then there's some other content where they might go, no, I don't think so. So it's a relatively straightforward design, and it really should let us unpick this problem of who's susceptible to this misinformation. So hypothesis number 1. Well, let me add, this is all for research question 1. This is all for individual level factors. So the first one is institutional trust. And here there's really 3 parts. So there's institutional trust, belief in conspiracy theories, and openness to experience. The idea being that if you believe in conspiracy theories, or you're more likely to believe in them, or you believe in them to a greater extent, then you're more likely to be more susceptible. Belief in conspiracy theories is in turn a product of having low institutional trust and high openness to experience. And there's been a lot of work which shows that there are connections between institutional trust and believing in conspiracy theories. Openness to experience is a little different because it's a psychological factor, but it's still also been shown to have a very strong relationship with conspiracy theories. Hypothesis 2 looks at health literacy, and this is one that we're really interested in because we have 2 measures. So we have the actual health literacy, which a very, very simple measure. So people are given 40 terms, half of which are genuine medical terms and half of which are just made up. They sound vaguely plausible medical terms, and your challenge is to separate them into the 2 buckets, and you find that people who actually know something about health and medicine are pretty good at doing that, and the rest of us sadly really struggle. So that's a really useful measure. And then we also have the self-perceived health literacy, and this is really important because one of our hypotheses is that people who have very low health literacy but they think they have very high health literacy, they're the ones who are going to be most susceptible, because they're probably the ones who don't scrutinize things enough and perhaps don't question things enough. On to hypothesis number 3. Really, this is 2 hypotheses. So cognitive skills and digital literacy. I'll just comment on digital literacy first. So that's fairly straightforward. The more digital literacy you have, the less susceptible you should be. This is actually quite an important one in many ways, because what you realize is that a lot of misinformation is not just blatantly false, it's perhaps satirical, or it's trying to attack someone or lampoon them, and therefore it uses lots of very internet specific modes of communication. So there's this idea of shit posting. There are these animal memes, and if you spend a lot of time online, you start to learn these things, and you start to realize that maybe someone's being satirical. You're therefore less susceptible to that sort of content. However, if you haven't spent a lot of time online, you might not realize that internet culture. The other one is cognitive skills. Now, in principle, cognitive skills makes a lot of sense. So, the more critical you are, the more you scrutinize things, there'd be good reason to think that that has a positive relationship. A positive relationship on your ability to discern truth from false content. That's one way of approaching it. But there's a lot of evidence which suggests that health-related misinformation and misinformation in general isn't just a question of cognition. It's also a question of your non-cognitive factors, and it works on a very emotional level. So just because someone has a very high cognitive skill set does not mean that they will necessarily be better at making those judgments. And that's why we hypothesize that there won't be any relationship here. Hypothesis number 4 is personal vulnerability. Now, I should apologize straight away. This is a mistake. This is the same image as the previous slide, as hypothesis 3. But that's fine. So just to be clear that this is not the correct image. And with this hypothesis, there's competing schools of thought. So one strand of the literature says people who are vulnerable to COVID-19, people who have health problems, they're more likely to be better at judging truth and false content because they're going to be more informed. They're going to have learnt more about it. They're going to be far more critical. The other side says that actually, no, these people are too close to the matter. They get too emotional. They might overthink things. They are too invested. It's very hard for them to make appropriate judgments. And I'll say that here, our view is that people who are more vulnerable to COVID will also be more vulnerable to COVID-related misinformation. But I think this is a space where the research really is very open, and we're really interested to see what the results show. We also have some additional hypotheses and control factors, so age, gender, ethnicity, geographical region, education, time spent online, personality traits measured in terms of the big 5, and political leaning on a left to right scale. And political leaning is really important for the second research question, which I will now go into. So the second research question is, what features are associated with false health-related content that people believe to be true? So the first thing we're going to manipulate when we show people content to assess is the source of the content. So news providers, and here we split into left and right, high to low quality. And that's why it's really important to have the political leaning, because obviously for news providers, politics is a huge part of it. And so we need to be able to account for that. The next one is institutions. So does it come from, say, a public health body like the WHO or a UK government? And then lastly, is it an interpersonal contact? So obviously we can't emulate an actual interpersonal contact for each person, but it's just a generic person who's sharing the content rather than one of these established institutions. The second factor is how the medical claims are presented. And there's this very interesting part of internet culture called Betteridge's Law, which says that whenever you see a news title or a news headline which ends with a question, the question is nearly always to be answered negatively. As in, when you see those very sensational, revolutionary, exciting stories which are asking the question, oh, does X hate Y? The answer is nearly always no. No, they don't, or else you'd have put it as a descriptive statement. So we think that's going to be a really important factor. Then the last one is the type of claim. So the health-related misinformation can relate to many things: the virus spreading, how we tackle it, the causes and origins, and it's very plausible that people will have different levels of vulnerability because the public understanding about those different parts of COVID really do vary quite substantially. So where we have got to, and I do realise that I'm just coming just up to the 15-minute mark, so my apologies for running over a little, but As of me writing this, which is at the end of July, we've confirmed all of our ethical, legal, compliance, data security requirements. This is a project which involves quite a lot of different moving parts. It involves taking medical information from people, their outlook on political issues, gender, ethnicity. These are very sensitive things. We're also showing people health-related misinformation, and we have a very detailed debrief session, but we have to make sure that we're handling this in the right way. So huge thanks really to everyone at the Alan Turing Institute who has supported us through this process. We have confirmed our pilot study and we're waiting to get the responses back. We're then ready very quickly to move on to the full study to confirm things on OSF before we do that. And we should be delivering by September. And we will be delivering a report. We're going to be doing blogs, public-facing events. We'll have the technical report out in September and then a full academic publication coming a few months after. So I'd really just like to say thank you very much for taking the time to listen. This is a really exciting area of research. It's very, very interesting area, lots of methodological, theoretical challenges, but of course it does also have quite a serious impact on people's well-being, and we hope these results will actually meaningfully inform the work of policymakers and government in how they target support to people. So if you have any questions or queries or criticism or feedback or advice or anything, please just send me an email and I'd be more than happy to address them. Right, thank you very much.